Well, good afternoon, everybody. And the sun's about to shine, I think. I'm come from California these days, so I have to have the sun travel with me for some moments of the day. So it's really a pleasure to be here, to be invited, and to actually discuss newborn jaundice with experts like you who actually have made newborn jaundice and connectors relatively rare in the United Kingdom, and the work that was done by Donald Manning was just incredible. It was a light in the tunnel when we were dealing with these issues in the US. And as Dr. Ives just started to end that particular video, I was there when it was being filmed, and the other face in that video, which was a separate part of the interview, was Cal Sheridan. And Cal Sheridan is this beautiful golden-haired boy who was about 4 years of age now, and he's about 24 at this time. And when Cal was born, he looked very normal and beautiful at birth, good APGAR scores, and went home at 2 days of age, slightly jaundiced, and was told by the pediatrician to put the baby in the sun. And at 3 days of age, less than 72 hours, the baby was back in the emergency room being seen by the pediatrician, who thought the baby may have had an ear infection because the baby was kind of arching his neck back and was crying inconsolably. And was just so irritable and not eating that he was admitted to the hospital for dehydration and start of antibiotics, and was diagnosed on his medical records as having otitis media. I don't know very many children who at 3 days of age have otitis media, and especially in the US, I mean, that is highly unlikely. And no bilirubin value was done, I believe, at that time. And the baby subsequently seemed to recover. The jaundice that was there faded away, and the baby went home, and all the serial photographs you saw of him were of a blank face, eyes that just stared and did not blink. And as he grew older, he had incoordination, and by a year of age, he was diagnosed to have cerebral palsy. And the mother, who is a brilliant woman, searched high and low to find out what was wrong with her child, because why would otitis media cause such a problem? And at 1 year of age was diagnosed, as I said, to have cerebral palsy, and then at 3 years of age, as the picture evolved, somebody outside, Dr. Volpe actually in Boston, who's the world's foremost neonatal neurologist, saw him and said, "This baby has connectris." And she said, "What is connectris?" And she went back to Google and searched connectris and said, "This is a disease that occurs in the third world." Realized that her own blood group was O and baby Cal's was A. And this was a classic case of an avian compatibility with hyperbilirubinemia that had led to connectris in the first 3 days of this baby's life. And so that becomes the basis of their effort to inform the AAP when we were developing the guidelines on how we should be more careful and cautious and educative of the families and what they deal with, and how we can help them at least make sure that their children are protected. So my topic here is the role of the AAP guidelines to identify neonatal hemolysis. All right. It was a task that we could not complete about 12 years ago. By the way, I have no financial disclosures to declare, no conflicts of interest related to either the CoSense device or to my research, other than it's been funded by the government and by our foundation. And I'm required to do this as for university regulations. So what I hope to chat with you about are three things. You heard a little bit about this discussion in the earlier talk on the bilirubin algebra that we need to be familiar with. To review the evidence that could guide clinical practice and implement a hemolysis screening device in clinical practice. Now, neonatal hemolysis we classically know as an isoimmune hemolytic disorders, but there are many other causes of hemolysis, and those of us who have taken exams in neonatology or in pediatrics remember all the causes for neonatal hemolytic conditions, as was shown to you by Dr. Ives. And the burden of this neonatal hemolytic diseases worldwide was recently published by us, where we think about 24 million babies every year are at risk for having hemolysis. That's about 18% of all births. Of these, a smaller proportion, because most of us practice good medicine, are able to reduce their connectors to like 0.38% of birth globally. You saw the incidence in UK. But as a director of the CDC said to me, one case of connectors is one case too many. And with this burden, the rate of connectors and RH disease still remains a huge issue, but ABO incompatibility and hemolysis, classified as EHB, extreme hyperbilirubinemia, is, by levels of uncertainty, is a fairly substantial amount. So I think at least 1 million babies a year are damaged in one form or another, whether from prematurity or extreme hyperbilirubinemia or RH disease, from a disease that is completely preventable, completely. Where an exchange transfusion is such a rarity that it's like a crash landing. So just as airline crashes are extremely rare, so should connectors be. So since hemolytic jaundice was the mainstay in the last century of trying to promote the management of children, if you those of you who are old enough like me will remember that 150 years ago, I am that old, is a diagnosis called icterus gravis neonatorum. All right, I don't know how many of you have read that word, but that condition doesn't exist anymore. And there was another condition called hydrops fetalis. Those two conditions had the same origin, hemolytic diseases of the newborn, mainly RH disease. So as we figured out how to manage hemolysis, we came up with different ways of trying to assess the diagnosis of hemolysis. So the hematological studies we do are to look at a peripheral blood smear where we crush all the red cells and the two slides and look at them under the microscope. So that's not the best way to do it. We look for Heinz bodies, which I'm sure I have not seen very often. We look for G6PD deficiency and pyruvate kinase enzymes as the major enzyme conditions, rarely done routinely. Urine analysis for free hemoglobin only when the hemolysis is extreme, and those of us who have seen cases of black water malaria know that. Serum haptoglobin, we don't have normal values in children, or let alone in newborns, or we follow serial hematocrit the first week after birth, which we know fluctuates by the rate of hydration of the baby. So that set is completely useless to us at the bedside. From a chemistry point of view, we can do a bilirubin, or we can look at the rate of rise of bilirubin, or we look at the hour-specific bilirubin value because it changes by hour, and therefore it gives us the rate of rise of bilirubin in a more specific term. And in the 1940s, one was able to measure carboxyhemoglobin as a measure of bilirubin production. So in 2004, when we did write these guidelines out, we tried to look at how to define hemolysis. And as we looked at that, I will highlight in this particular area, is that most of these investigations that I've talked about had poor specificity and relatively low sensitivity. So they were completely unhelpful or often unhelpful. And based on the evidence that was available in 2004, enough evidence of the work done in the preceding 20 years had been done on the role of carbon monoxide as a possible measure of bilirubin production, and we'll talk obviously a lot about that. So the traditional measures were to look at rate of rise of bilirubin. And in the RH days, a bilirubin value rising more than 0.5 milligrams per deciliter per hour, that would be about 7.6 microliters in your units. And that was the threshold for exchange. And then said, oh, okay, maybe half of that is also modest enough and it's high, and came up with 0.25 milligrams per deciliter per hour. And I've provided the evidence that a rate of 0.2 milligrams per deciliter per hour based on the 95th percentile track for age from 0 to 72 hours is a high level for us to think of. So that if we plot these numbers on the 95th percentile track, oops, this is not good. What did I do here? There we go. All right. The 95th percentile track, if you see, is the steepest between 12 to 72 hours of age. That is about 0.2 milligrams per deciliter per hour. So you can multiply that by 17.1 and you can come to the units. Now this is one baby with an ABO incompatibility who's had 3 measurements of bilirubin done, and you see them progressively going up in a very linear manner. And that is one way you could use the nomogram and say, wow, this baby's bilirubin is going out for a sixer for those of us who play cricket. However, if you look at this a slightly bit more closely, and you say, if I start off at 2 milligrams per deciliter, that line absolutely continues in a straight line. And why did I come to 2? Because 2 is the 95th percentile bilirubin value at the cord blood for most babies and healthy babies. So a bilirubin value of 2 milligrams per deciliter per hour in the cord blood will give us that number. So based on those numbers, we basically define risk, we can define a trajectory, and we can project where the baby's bilirubin is going to go, because for the first 5 days, the bilirubin is going to rise up in a linear manner, unless the baby is eating so well and is thriving so well that it will start to drop after the 3rd day. So that's one way of playing this game, of trying to predict. So now let's look at another segment of a population, and this is a child who's 3 weeks of age. And this is where I'm on a personal crusade to abolish the diagnosis of breast milk jaundice. I think the ICD-10 code needs to be established and expunged out of our memories. And the reason for that may be illustrated by this case. A 3-week-old female preterm infant, 32 weeks AGA, born of Taiwanese ancestry, with a history of 3 episodes of phototherapy being used for a rising bilirubin value. They would, bilirubin would rise, they'd get phototherapy for a day or 2, stop it, then it goes up again, up and down. This baby had an interesting family history. The maternal uncle and a cousin, who's the son of the maternal aunt, both had diagnosed G6PD deficiency, because in Taiwan they routinely screen for G6PD deficiency. Except this family moved to the US, where we don't routinely screen for G6PD deficiency. So in all probabilities, given the baby's G6PD enzyme level that we measured of 6.1, this baby was a female heterozygote for G6PD deficiency. So you don't have to only be male to have G6PD deficiency. And we measured the carbon monoxide value in this baby. And I'll come back to this number of 1.8 parts per million at age 2 weeks, which indicates a low-grade hemolysis. We also measured the UGT enzyme PCR. We didn't measure the enzyme, we looked at the gene, and the baby had polymorphisms for UGT polymorphisms. So this baby had G6PD deficiency, a heterozygote, mild hemolysis, and an elimination problem related to liver immaturity. So if I was to take these ingredients of this case and take you to simple algebra, I know most of us don't like algebra, but bilirubin at any one given point is the level or the load of bilirubin, and it equals the production of bilirubin minus the elimination of bilirubin. Simple, right? Can't be more simpler than that. So this equation was actually developed by Timos Veles, another Greek neonatologist. And I adapted his equation for a while, that the rate of rise of a bilirubin load, because it changes hour by hour, equals bilirubin production, which is due to hemolysis, minus the bilirubin clearance. And there are two components to this. One is the maturation of the liver, which is under the UGT gene, and the second is the maturation of the gut with its feeding. So a starving baby, a starvation jaundice baby from inadequate breast milk is the other, has that problem. So it allows us to focus therapies at how to manage a baby with a rate of rise of bilirubin that is increasing. And this equation becomes an aid to inform clinical judgment. Should I focus on the feeding? Should I push on the feeding? Should I wait for some days because the liver is mature? Is the baby is premature? Is the UGT enzyme working or not? Or is there hemolysis going on? So it helps you kind of focus on all of these issues. And we do this only by looking at that first red-lined black box, the rate of rise of bilirubin. So we are missing out a collage of other things that are going on in this baby. So the baby whose story I just shared with you from Taiwan is a baby who I think is like the volcano waiting to erupt. And these are babies with jaundice beyond 2 weeks of age, who, if they are exposed to an oxidative stress, such as a viral infection, a bacterial sepsis, or a drug, if they're G6PD deficiency, or simple things like henna from the hair color dye when the mother tries to change her hair, she finally gets her hair shampooed after her delivery, and puts on henna to bring some highlights to her hair. I mean, that may trigger this hemolytic reaction. There are varieties of conditions that one has to keep in mind. Or if there's late prematurity, all of these can trigger this extreme hyperbilirubinemia, the classic case that we worry about when babies come in at about 2 weeks of age with the bilirubin in the 500 to 600 units and so on. So this baby, the only signal we had this baby not been Taiwanese, was a low-grade hemolysis that was going on for this baby. So when heme breaks down, it breaks down into bilirubin and equal amounts or equimolar concentrations of carbon monoxide, which binds to hemoglobin to make carboxyhemoglobin. This carboxyhemoglobin then travels to the alveolar surface in the lung, and we breathe it out. Luckily, the concentration of carbon monoxide in our atmosphere is relatively low, so we can actively breathe out and we don't have to inhale it all in. But if we are smoking, then we get a lot of carbon monoxide. So if you are sitting in a room full of smokers, like in one of the airline lounges behind the camel and the glass screen, the concentration of carbon monoxide is about 400 parts per million. And if you remember the concentration I showed you that was measured in this Taiwanese baby was 1.8 parts per million. So we're talking about low levels of carbon monoxide. Putting this together with the work that has been done earlier on in techniques to measure bilirubin production, you can either look at carboxyhemoglobin or you can look at the end tidal carbon monoxide concentration. And there are a series of work that have been done in this area, so that's not the function of the slide, just to illustrate that this is nothing new. There are also other endogenous sources for carbon monoxide, not only from the red cells that are dying down, but from ineffective erythropoiesis and other hemoproteins. And there are other non-heme sources, such as from lipid peroxidation and photooxidation, things that we have to keep in mind. But the major component, about 80%, are from the red blood cells. So a device was created in 2000 and about 2000, a couple of years before that, and my good colleague and partner David Stevenson led a global study using that device marketed by Natus to see if we could predict hyperbilirubinemia in term and late preterm babies using carbon monoxide testing versus bilirubin testing. So I was pushing for the bilirubin testing and he was pushing for the carbon monoxide testing, and the answer obviously was somewhere in the middle. What we learned from the study was a great deal. We found that the carbon monoxide level fluctuated in those babies in a fairly Gaussian distribution. And this was at about 30 hours of age. You can measure it as early as 6 hours, because we often don't know the mother's history of smoking, so we don't want to collect data before 6 hours. But since we were doing bilirubin measurements at 30 hours of age, these are the simultaneous measurements, and you see a nice Gaussian distribution of carbon monoxide. The question was whether pre-discharge evaluation of ETCO predicted severe neonatal hyperbilirubinemia. And what that study actually showed was that bilirubin and carbon monoxide together are effective, but carbon monoxide alone could not, because it was only focusing on one half of the equation, the production part, but not featuring in what would happen with the elimination part. So the guidelines were written, and the guidelines felt that if you could measure the carbon monoxide, that would be helpful in at least diagnosing hemolysis or screening for hemolysis rather than predicting hyperbilirubinemia. So these guidelines have now been implemented in California as well as in many other areas of the US. And they have a certain set of laboratory assessments that included ETCO measurement if available. And there are a series of risk factors, again ETCO if available, clinical pathways, again ETCO if available. So the intent has been there, but there was no such device. This illustration also showed to you by Dr. Ives illustrated our thought that hemolysis was a factor along with sepsis and lethargy and so on, but is more generated by the fact that none of us sitting at that table, among the dozen of us who were at the table who had a voice in choosing these numbers, had any true evidence at which phototherapy should be given. And these are just gestalt numbers. We all realize that bilirubin value alone is not an indicator of neurologic injury, as Dr. Ives shared with you. That there's something more, whether it is the low albumin or whether it is the rate of rise of bilirubin, or was just prematurity. And this was our attempt to try and separate out 3 different risk groups again. And that is why a baby who is 36 weeks of gestation has an ABO incompatibility, needs to have an exchange transfusion done, a phototherapy started at 257 as compared to a term baby with no ABO incompatibility, which can be done at 350. So that was the differentiation. So here we have been practicing now a tool for more than a decade for which there has been no scientific evidence. prospectively collected. However, we continue to practice, and these are 4 US-based studies from different areas and different communities, different healthcare systems, and their rate of use of phototherapy. And as you see, it varies from about 4.8% to 8%. And in fact, in the Kuznevec study that was also showed earlier on, the phototherapy rate was as high as 14.8% in one of the centers, and I've heard about other centers using phototherapy in 20% of their babies. But some centers, only 4.4%. Are we less aggressive, or are we just foolish? I don't know. So we have to figure that out yet. But what has happened is by using intensive, multiple, effective phototherapy, at least in a regimented, standardized way, we were able to show in California that the incidence of babies with bilirubin values above 425 have actually decreased after the initial reporting period when we were collecting data, and that our rate of exchange transfusion has gone down, so that our rate of exchange transfusion is about 2 per 100,000 live births in the US, in California. And that's a very diverse population. And so that's a remarkable decrease over the last 7-8 years. So now that we can measure carbon monoxide level or bilirubin production, is it helpful? And is it necessary? And this assumes basically certain benign outcomes that we know of that actually work in the nursery. We have a good response to phototherapy. We use phototherapy in a prophylactic manner. We assume the serum albumin is more than 2.5 grams per deciliter, and we are learning that it's not. That there are no significant competitors to albumin binding that we give to babies because our FDA is so rigorous, but we have not excluded hemolytic disorders. And this data comes from Dr. Christensen's group in the Intermountain Health System. So he works in an area which is predominantly Mormon, predominantly white, all right? And as they were able to reduce their rate of bilirubin values more than 427 micromoles per liter, the ones who had high bilirubin values still, 74% of them were idiopathic, 8% had a positive Coombs test, 14% had birth trauma, again hemolysis, and 1.6% had G6PD deficiency. And it's in that 7.4% that he worries that there may be undetected hemolysis or then a UGT polymorphism. And so he's written a lot about all the red blood cell disorders that actually exist in his population. So when we talk about ABO incompatibility, we're not relying just on the Coombs test. Coombs test is not the measure of incompatibility. Incompatibility is when the mother is O and you have the baby either OAB, or the mother is A and the baby is either AB, or mother is B and the baby is A, and therefore the incompatibility is BA. So those are the different incompatibilities that can cause varying amount of hemolysis. And as allergy season begins, I know that the British have a different system than the Americans. For us, the allergy season begins in fall. There is a potentiation of the number of kids who get admitted with ABO incompatibility with hyperbilirubinemia. So there's a seasonal variation as well. I won't quote this study from Dr. Newman that you have just mentioned, indicating that there is a concern that hemolysis by itself can add to the risk of neurotoxicity. And so I'll move on from there, but bring your attention to a syndrome that is less severe than kernicterus, for which there has been an accumulated evidence. This is a clinical syndrome of bind, and we've called it dysfunction because we are looking at the molecular cellular component of injury, and then there's a question related to damage, which is also related to more at a cellular level, whereas the dysfunction is more at a functional level. And these are children who have bilirubin values between 350 to 427, who don't get connectors, who may have sustained hyperbilirubinemia, who do not remember their history of having had jaundice, at least at that time. And then as they get older and they start going to school, they have problems with subtle hearing impairment, language development, aphasia, fine tremors, all these things that were being noted by Dr. Newman in his reanalysis of the study. So this syndrome to me is worrisome, because this has a long-range impact, and I've met many, many, many nurses, in fact, who children had borderline high bilirubins, and the people had elected not to be aggressive with them, and now at the age of 14, 15, they're seeing the impact of on the language and their performance in school and high school. So let's bring it down to the actual testing and screening. We have enough rationale for this. So we looked at the ETCO device, the one that you see here on display, and we were able to work with the company, who were very gracious enough to work with the Stevenson lab at Stanford, and to help in making an operational device. But what they did was something unique, was they looked at the ability of the device to measure the carbon monoxide levels in the expired breath. And it kind of remembers the breath, because you want to get the tail end of each breath, and is able to do it in a prospective algorithmic manner. So we did a bench evaluation for this device at different concentrations of carbon monoxide. And we correlated these also with carboxyhemoglobin values with a good correlation. So in two different settings, we looked at two different components of carbon monoxide concentrations, and we looked at 3 devices to see if there was an inter-device comparison. And this is the data that we have published in Acta Pediatrica, and we found that this was an effective device, a better device than the one that we had previously worked with, and were really kind of complimentary of the industry for having found an innovative approach to the expired breath collection, which I'll come to in a moment. We correlated in a small group of babies the relationship between carboxyhemoglobin and ETCO device. That outlier number is a baby with Rh disease that we happen to get, and you can see it helped kind of project this line and change the scale of this particular picture. We looked at babies with hemolysis at different ages in hours and related them to their nomogram status, and the triangles indicate the babies who are high risk. That means they have high bilirubin loads, and you can see their carbon monoxides being all over the place, which is not unusual to what I expected to see. So as we put all of this information together, I want us to think about carbon monoxide, not just only our way of trying to look for hemolysis, but in trying to understand the bilirubin load. All right? And part of this are looking at the different tests. You heard about the bilirubin-albumin ratio. We can measure free bilirubin. We can measure the binding capacity of bilirubin, just as we measure iron binding capacity. And now we can measure hemolysis. And all of them kind of work with each other. And the classic example for me is, for those of us who work with babies, is to know a baby's respiratory status. We do a blood gas evaluation. A blood gas evaluation uses pH, PO2, PCO2, and calculates the bicarbonate. But each of those technologies took about 10 to 15 years between their development. So we never learned to use all the sets at one given time. We have learned it over time to interrelate with each other. So nowadays, if I'm given a blood gas, I don't have to think too much because I've learned to integrate that information in my head. And it's very similar with what I call the biomarkers. That's just like the pH, PCO2, PO2, and bicarbonate. The biomarkers are like the total bilirubin, carboxyhemoglobin or the ETCO measurement, the bilirubin binding capacity and the unbound bilirubin measured as a ratio, and the albumin, which is like the calculated or the bicarbonate value. Now, if you can put this together in an algorithm, in a few years, when we put this information, we'll be able to better understand the bilirubin panel and the load of this baby. So keeping that in mind, let's see how do we apply this clinically. So first thing I did was I reanalyzed the 2001 data from Dr. Stevenson's group. And out of the 900 odd babies that he had, I looked at their bilirubin in the risk zone areas and their ETCO measurements. And I looked for babies who had bilirubin ETCO values above the median value of 1.6, shown in this column. And in the high risk group, about 80% of the babies were hemolyzing. In the high intermediate group, almost 54% were hemolyzing. And in the low risk group, there were still some babies who were at the risk of hemolysis. I'm not saying they're hemolyzing, they just have a higher bilirubin production than expected. So there is a variation, but it isn't as if there is no higher bilirubin production in any one group of babies. So this helped us design the single study that we've just reported, and there's another study that we've just completed as our American study, and we looked for identification of neonatal hemolysis. So we were looking to see that the corrected end-tidal carbon monoxide level, and the small c is important because you have to adjust it in different nurseries with the different amounts of carbon monoxide in that nursery on that given day, and look at the simultaneous measurements of serum bilirubin, and we wanted to see also what the ranges of the ETCO look like so that we could support a clinical idea at least. So same group of babies, late preterm and term babies in our nursery. We excluded babies who needed to be on respiratory support or weighed less than 2,000 grams, or mother with a known history of smoking, and any subject who had a problem with the device, and there was none with that. Looked at the ETCO measurement with this device provided to us by the CoSense group with no expectations from us, and total plasma bilirubin measurements made in a standard laboratory in the plasma. And this was the operational behind the black box of the CoSense device. You see the expired breaths. There's a circuit in there that helps capture the expired breath and then can give us a measurement almost simultaneously. Put it on the bilirubin nomogram, and we were looking at where these were in the baby as a follow-up. We enrolled a bunch of babies. We got 4 measurements on each baby, and we were able to track them, collect the data, and did a statistical analysis. So, remember the first Gaussian distribution I showed you? We got a very similar Gaussian distribution with a small tail end over here, and what is interesting is that values of about shown there in this red mark at about 8 or 9 is like excessive hemolysis, and there's another baby who was here at that point that had the RH disease, and the 95th percentile track, 75th percentile track. All right, that was a little off. I think the whole scale went off for some reason. Problem with the slide. This was the log version of the same Gaussian distribution. And these are different measurements of ETCO measured over time. And you can see the ranges kind of blending through in a range from about 1.4 to 1.2 to as much as 2.5. And then you see the high outliers, the one with high levels of bilirubin production. There was one baby who had a very low value, but other than that, what we're looking at in our multinational studies, how each baby kind of does and track himself if they were high, and how long does it take for them to become a non-hemolyzer baby. Okay, I'm going to move on a little fast from here. So these babies, we separated out in those babies who had bilirubin values above the 75th percentile. We have most interest in those babies, and separated them out with the ETCO values being less than 1.6 and above 1.6. And so if you had a high bilirubin value and you had a high bilirubin production, then though there were 24 such babies in this small group, again about 77%. And you see the incidence of ABO incompatibility and bruising and so on, as well as racial and ethnic differences. So in this particular study, we were able to just show that risk due to hemolysis alone could be detected by this ETCO device, independent of the risk detected by bilirubin values. And above the 75th percentile track, a majority of the babies had ETCO values above 1.6 parts per million. So this was the first step. And that these were helpful for us to start defining some clinical algorithms to test in a future study. And I just want to move on faster because I'm running out of time. So to help run this study in our nursery, and it was predominantly because when we are running a study in the well baby nursery, the practicing nurse, the midwife, as well as a physician wish to know what is the value of the data that we have collected, because it's being done in an open manner. And so should it influence their management or not? So we came up with this algorithm that you first looked at clinical risk factors. That was important. You looked at the bilirubin screening, which is part of our routine practice in the nursery. The clinical risk factors are maternal race, ethnicity, gestational age less than 39 weeks, bruising or cephalhematoma, and jaundice at age less than 24 hours. And then if you had a bilirubin value of the 75th percentile, we did an ETCO evaluation. The high side, that is 2.5 parts per million, and a rate of rise therapy. That baby needs to be triaged. Then you come to a second group where the ETCO value is between 1.6 to 2.5, maybe a risk of hemolysis, and the rate of rise of bilirubin is high. And that baby should get phototherapy, but it is your judgment to do that. Or you can follow serial bilirubin values, or you can work on feeding, and so on. But if your ETCO value was less than 2.5 and the rate of rise of bilirubin was less than 0.2, that's baby who needs close evaluation and needs to be remaining under medical supervision. And we are trying to figure out what we should do with this group of babies. How much should we worry about them? And that is the largest study we hope to do. And we have, as I said, an American study which has about 300 odd babies, but we need to collect about 2,000 babies to be able to prove this kind of an algorithm. So this is open to debate, obviously looking in many other different ways so they can help our clinical bedside decision-making process. My hypothesis is that if we target with evaluation to the babies who only need urgent phototherapy, that we can actually reduce our rate of phototherapy down to a very low number. So the use of phototherapy becomes an outlier rather than a standard practice. Why is this important? Because not only are we working with phototherapy, but we are also looking at heme oxygenase inhibitors. And here we have a trial where it actually makes a difference. And this is a single-dose 10-mesoporphin study that we just reported, in which, based on a TCB value, a transcutaneous bilirubin value of 75th percentile and above, the babies were randomized to either getting a sham injection of 10-mesoporphin or getting the 10-mesoporphin itself. Similar inclusion criteria: babies in the Well Baby Nursery. We enrolled at 6 sites about 916 babies, of which 213 had a bilirubin value above the 75th percentile, about 23%. And pre-intervention serum bilirubin values, after the TCB had been obtained and we were giving the drug, we got the serum bilirubin values, were about 7.6 to 6.9, which is not a very high number, all right? We're talking about 150s to 200 range numbers over here. And after giving the drug, you see that there was a reduction in the rate of rise of bilirubin. And there was a reduction, actually a drop, in the bilirubin increase that normally occurs in the first 7 days. And the duration of phototherapy, though that was not our primary objective, actually halved in a matter of hours. So we did not test them. So we were looking at this efficacies, a variety of them, but this is a figure that I needed to show, is that by giving a single dose 10-mesoporphin to a baby somewhere around 30 to 36 hours of age, you can change the trajectory of the rise of bilirubin. You still need bilirubin because it is a good molecule. It's a great antioxidant, but you don't want it to be too high. And over a 7-day period, you can see that the magnitude of hyperbilirubinemia has been sculpted down. So in a situation like this, one could inhibit bilirubin production and measure it with carbon monoxide, or one can use phototherapy with basis on the carbon monoxide level. So in the last slide is that the take-home messages are quite clear, to me at least, is that 1 out of 4 babies have increased bilirubin production, average. That we can identify those at most risk with non-invasively using an ETCO device. That untreated hemolysis may lead to short and long-term or lifelong manifestations. Connector is relatively rare, but the bind syndrome that we need to focus on. And we still have a few more questions to answer, that if we can identify hemolysis and if we can prevent it, will the neurological risk go down? And that is an important question for us to prove. I'd like to thank our team and the Stevenson Lab and my team that have worked together to make this happen. Thank you.
Do you have any question to Professor Bhutani? If not, sorry. Yeah. Rakesh?
Sorry. Thank you. I just want to ask that serum bilirubin measurements in this algorithm. Yeah. Is it any possibility of changing that to transcutaneous?
Sure.
And because if we can do that, certainly in the UK, for example, we could use ADCO and transcutaneous and avoid the need for a pill prick to the baby. And can be all done in the community, so baby doesn't need to come to
those are wise words, and wise expectations have been part of my dream and aspiration. The current transcutaneous devices have technologies that are about 15 years old. The skin reflectance spectrophotometers, and they could be better, they could be cheaper, they could be more responsive. At this point, they are good screening devices. They can predict serum bilirubin value in either direction, so you don't know whether it's up or down, and there's like a guess. And in a dark-skinned babies, they can be completely be a problematic issue. So I think more work needs to be done in that area to improve the quality. But as we did in our study, we did use transcutaneous measurements. So as a screening to do a TCB as well as an ETCO device makes sense at home. I think we need to diagnose hemolysis earlier before jaundice appears. Because if we consider that jaundice at the age of less than 24 hours is a medical emergency, because it is a medical emergency, because it's most likely hemolysis at that time, that first you need to know that the baby is hemolyzing even before the baby is actually jaundiced. So you need to test that baby between 6 to 8 hours of age. And the jaundice may not be present or may not be seen, or the room may not be well lit, or the skin may be too dark, and so on. Transcutaneous measurements have been shown very effectively in several studies, including ours, to be very predictive of pre-discharge evaluation done at about 24 hours of age. So I think we need to blend them together, but we need to do them in a very deliberate manner. Kevin, sir. I'm scared.
That was a fantastic presentation, and I think your idea of a panel of sort of tests that we do on a child, and including the end-tidal carbon monoxide, the bilirubin to albumin ratio, it may lead, as with the sort of the bottom box in your algorithm, where you said urgent phototherapy, to a baby being treated with phototherapy at a level that's below our conventional intervention lines. Is that what you envisage?
Yes, right.
Yeah.
Right.
See, I think that's exciting, because people might say, well, actually, aren't you going to end up by treating more babies with phototherapy?
Yeah.
But actually, no, you're going to be perhaps treating fewer, but in a targeted way, using thresholds which aren't conventional at the moment.
That is
and I'll
exact-
show some examples this afternoon by what I mean by that.
Yeah, that's precisely. I think there's always a learning curve when people start get used to things. I mean, it's like with PCO2. You know, we didn't believe in permissive hypercapnia until we said, okay, we don't have to ventilate that kid. It's okay for the CO2 to rise. So, thank you. All right, we can break for lunch and then we'll have some discussion.